welcome to the EAU podcasts.
So welcome to a new episode of the UROONCO Kidney Cancer Podcast. Today we will give a tour through the key highlights in kidney cancer for 2025. I am Carmen Mir, the UROONCO Kidney Cancer Chief Editor. Today I'm joined by my three fantastic associate editors and colleagues, Dr. Carlotta Palumbo, Teele Kuusk, and Riccardo Bertolo. So Carlotta, in 2025, it brought a lot of discussion on early detection and smarter diagnosis. What stands out for you in those terms?
So thanks, Carmen. So first of all, I would start with early detection. Indeed, we do have the final results of the Yorkshire screening trial. So basically, patients were screened for lung cancer with a chest CT scan, and they were further invited to have abdominal CT scan. So what the study found was that the number needed to screen to detect one suspicious renal lesion was 93. Even though this number seems to be high, actually it is aligned with other screening programs such as colon cancer, for example. This is definitely the first milestone for further studies to assess the true effectiveness of a screening program on kidney cancer. But in the other hand, we do have some novelties also on non-invasive biomarkers that may be helpful, especially since we know that the CT scan may have some limitation in defining the nature of a renal lesion. For example, we can test for the presence of specific RCC proteins in the urine. A study presented at last EAU Congress identified 19 proteins that were present in both urinary, extracellular vesicle, and kidney cancer tissues. So basically, this set of protein may be used as a biomarker in the diagnosis of suspicious renal lesion to determine whether the mass is benign or malignant. Additionally, urine biomarkers may be used also as non-invasive follow-up after surgery. For example, a recent publication demonstrated that the increase of specific metabolites in the urine, particularly glycosaminoglycans, were related with recurrence after surgery, and notably were related to early detection of surgery compared to standard imaging, suggesting a potential de-intensification of CT scan during the follow-up period.
Thanks, Carlotta. I mean, it seems like so basically the future of kidney cancer diagnosis is really about integrating imaging, urine biomarkers, and biology there, rather than only relying on slides and imaging. So how about on the systemic side, Teele? In 2025, we had a very dense year as usual. A lot of stuff coming out on those terms, adjuvant, first-line therapies, and beyond. What should we remember as a clinicians from this year?
Thank you, Carmen. So I will start with SBRT, which is increasingly being incorporated into various treatment settings. In localized kidney cancer, it has now entered also the guidelines as an option for frail and inoperable patients, as demonstrated in the Fast Track 2 trial. However, longer follow-up and comparative data against other treatments and active surveillance are required before commending it more broadly. But in the oligometastatic setting, SBRT to metastatic sites has been shown also to prolong the systemic therapy-free interval to a median of 34 months through serial SBRT treatments. And this was demonstrated by Tang and colleagues from MD Anderson. Now moving on to adjuvant setting, we now have a second trial demonstrating a disease-free survival benefit with adjuvant immune combination therapy compared with observation. The Rampart trial presented at ESMO. It showed that 3-year disease-free survival was 81% versus 73%, with hazard ratio of 0.65, with benefit primarily seen in higher Leibovitz risk groups. Notably, this trial included also non-clear cell RCC histologies and high proportion of patients with Leibovitz high-risk disease. However, we need to bear in mind that 24% of patients completed the full durvalumab, which is PD-L1 inhibitor treatment schedule, and 73 received the two planned tremelimumab, which is CTLA-4 inhibitor infusions as per protocol. So now we're waiting this trial's overall survival data. Moving on to a neoadjuvant treatment. The NESCIO study from the Netherlands Cancer Institute demonstrated that after only 2 cycles of combination immunotherapy with ipilimumab, with nivolumab, or nivolumab with relatlimab, which is LAG-3 inhibitor, it showed that 14% of patients achieved a partial or near complete or even a complete response in their primary tumor. But we still need longer follow-up, and we know that with follow-up of 18 months, event rate for intermediate and high-risk Leibovitz score patients was very low. But we need to wait the longer follow-ups, and neoadjuvant treatment is not recommended currently in the guidelines. Now moving on to systemic therapy, there were many updates. For example, the Checkmate 9ER trial, which compared nivolumab plus cabozantinib with sunitinib in treatment-naive patients, reported outcomes at 67 months of follow-up, and it demonstrated a median overall survival of 46 months compared to 35 months with sunitinib. Hazard ratio was a bit higher, so 0.79, and progression-free survival was 16 months versus 8 months. Another systemic therapy update was on COSMIC 313, which was, as we remember, a triple combination trial with cabozantinib, nivolumab, and ipilimumab, and it reported follow-up of 45 months. The study demonstrated an improvement in progression-free survival with 16 months in the triplet arm compared with 11 months in control arm. However, so overall survival did not differ significantly between the two groups.
This is it in terms of systemic therapy. So I see, Teele, in short, IO remains the backbone, but we are kind of redefining the timing of what neoadjuvant, adjuvant, and oligometastatic strategy should be administered, no? I think that's what the take-home message is. Definitely triplets are not here to stay for us in kidney cancer. COSMIC 313 showed a lot of toxicity, and we will have to see if neoadjuvant is definitely the way to go in these cases. We move into the surgical perspective. So what's new in 2025, Riccardo, in terms of surgical innovations and robotics?
So thank you very much, Carmen. This year we have the publication of the OPERA trial first, which is an important randomized trial, prospective randomized comparison of robotic versus open partial nephrectomy for intermediate to high complexity tumor. Unfortunately, the study was with some limitation. It was stopped early and underpowered, but obviously give us a couple of important messages. First, there is no demonstrated significant difference in the 30-day postoperative complication between the two approaches. Both the techniques can be safe, and a high-grade complication were very uncommon across both the cohorts. From an oncologic and surgical safety standpoint, both are very valid. Second, obviously, there is a longer operative time and warm ischemia time for a robotic partial nephrectomy versus the open, but there is a benefit in the patient-reported outcomes. In fact, compared to open surgery, patients in the robotic arms had a shorter hospital stay, less post-operative pain, reduced opioid use, and better quality of life. And this was kind of important. So in summary, this trial did not show a reduction in complication with robotics, but demonstrated advantages in the early recovery of the patient, in the return to normal activities, I would say. The second important thing we featured in our platform was an interview with Professor De Backer that was at the EAU 25. We thought about the auxiliary technologies that nowadays we can use during our robotic procedures. First, it was outlined that we have nowadays real-time artificial intelligence capability in our operative room. This is rapidly evolving. We can use the augmented reality to track the anatomy dynamically with powerful softwares during our surgeries, maybe to help us at visualizing hidden structures, so maximizing the safety of our procedure with kind of a co-pilot during our surgical intervention. He's running the pod racing trial, which is testing all these technologies prospectively, trying to evaluate if this actually translates into improvement in our patient outcomes. So altogether, all these pioneer works are helping us to push the boundaries of our urotechnological surgery. And last but not least, obviously, we have the single pod robotic surgery. After a couple of years after the start in the United States, we now have many platforms installed in Europe. So in the field of kidney cancer, it is very important to highlight that the introduction of single pod robotic platform has kind of democratized a new retroperitoneal access to all kidney surgeries. This was once technically demanding due to the need for a complex docking of a multi-port, multi-arm robotic platform. Instead, with the single port, we have kind of a plug-and-play approach, which is nice also for the anesthesiologist because the patient lies supine, so it's very straightforward patient positioning. And actually, Professor Autorino, Professor Badani chatting with us within our platform, we're underlying that after a couple of minutes since the surgical access, we are dominating the renal hilum. We can visualize the kidney, the tumor. So this is very, very nice to expand the indication of an extraperitoneal kidney surgery.
Thank you, Riccardo, for that awesome summary of the surgical innovations that we had in 2025. So it looks like renal surgery is becoming like more complex, but also more precise and safer. Before we close, let's have a word on biology. And Carlotta, maybe you can tell us, what do you see as the next wave? What do we have in terms of biology improvement over this year?
So for me, we do have two new promising therapies. The first one is the better understanding of gut microbiome. Indeed, it has been proved that its composition may influence the efficacy of immune checkpoint inhibitors. For example, a disruption of the microbiome correlates with decreased immune response and with poorer outcomes. So therefore, microbiome-targeted intervention, such as, for example, the use of specific pre- and probiotics, may overcome this resistance. I think that in the near future, we can expect that these will be integrated more and more in clinical trials and treatment protocols. And the second one is a very fascinating new frontier, the vaccine. So basically, once specific neoantigens are identified on tumor cells, a specific vaccine can be created. So the most interesting part is that the vaccine stimulates a strong and durable immune response that is directed only against tumor cells, because actually the neoantigens are not present on healthy tissue. So we may have a personalized therapy with minimal autoimmunity that gives a very long-term response.
Thank you, Carlotta. And Teele, what do you see as the next wave in tumor biology for kidney cancer?
Well, there are some promising biomarkers in Horizon. For example, KIM1, which is kidney injury molecule 1. and this is a glycoprotein marker of acute proximal tubular injury, and therefore mainly expressed in kidney cancers that are derived from proximal tubules, such as clear cell and papillary RCC. And it has been investigated in randomized trials as a post-hoc analysis, and it has shown that, for example, decline in KIM-1 levels correlated with improved progression-free survival and overall survival in patients treated with ipilimumab and nivolumab in CheckMate 214 trial. And another post-hoc analysis was done in Emotion 010 trial in patients with high-risk resected RCC, and there elevated baseline plasma KIM-1 levels were linked to worse disease-free survival, but also to improved disease-free survival in those who received adjuvant atezolizumab versus placebo. So promising biomarker that needs further investigations. And another important treatment option for VHL patients is belzutifan, and this is also important in local disease. And it has been now shown at a 5-year follow-up in non-metastatic setting with the patients who had less than 3 centimeter kidney masses, that objective response rate was 70%, and it really reduces the surgical interventions in this patient group, and it is important for the patients for whom preservation of kidney function is particularly important. And of course, also in systemic setting, belzutifan is now in third line therapy setting superior to everolimus.
Thank you, Teele. Yeah, belzutifan is definitely a new molecule that it might take a good catch of what's happening. So all of these trials that you mentioned, either the neoantigen with the vaccine in RCC or the belzutifan, they pushes us towards truly personalized and biologically driven kidney cancer, which is a good thing. We are moving forward. So let's close in a take-home message for busy clinicians. So we spoke about early and smarter detection, opportunistic CT, plus advanced urinary biomarkers are moving into the spotlight over this year. Perioperative immunotherapy is also being reshaped. Seems like neoadjuvant is taking a spotlight as well. In the metastatic disease, immunotherapy remains backbone, while we are learning that other therapies might add. And finally, robotic surgery continues to expand indications and make complex surgeries more easily accessible. So far, Carlotta, Teele, and Riccardo, thank you so much for this concise and rich update. And thanks to all our listeners for joining our UROONCO platform. Stay tuned for the next episode, and we will tackle another hot topic in CU oncology. Merry Christmas and Happy New Year 2026.
Thank you for listening to EAU podcasts. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.